Hello again, this is Dr. Paul Barach talking to you today from Hospital Management Asia 2015. Today we'll be talking about the Patient Safety Certificate Program Pre-Conference. This is one of the podcasts in the series of podcasts as part of the program. Today we'll be talking about describing the elements of a successful investigation and event analysis. The topics of our podcast will be to establish an effective incident investigation program, to learn effective analysis tools relating to incident investigations, to learn how to conduct an incident investigation that identifies the contributory factors of the incident, and finally to implement recommendations that make sense to clinical providers and have a high chance of preventing future events. As you know from an analysis of the literature laid out in this slide, for the last 40 years, abundance of data shows that between 5 to 10% of healthcare leads to adverse care. This data goes back to the late 60s and early 70s in North America, in Europe, in Asia, in Africa, and in Australia. What's clear from analysis of these studies is that on a regular basis, at least 50% of adverse events are preventable. Many of them lead to death and disability, and many of them follow a common trajectory, that is to say, a sequence of events that clearly, when laid out, lead to an adverse event. What's clear when we compare the risk of healthcare compared to other industries, as we laid out in this paper that we published many years ago, healthcare is dramatically unsafe compared to other domains. The safest industries, as measured by a risk chart in the slide in front of you, are the nuclear industry and civil aviation, where less than 10 to the minus 6 events, or 1 in 100,000 to 1 in 500,000 of events lead to an adverse outcome, a crash or a fatality. As opposed to that, when you look into healthcare, on average, about 10 to the minus 3, or 1 in 1,000 patients has a preventable adverse event. And in high-risk domains within healthcare, such as cardiac surgery or pediatric cardiac surgery, as much as 1 in 100 might have an adverse event or die. In comparison to that, there are other high-risk domains outside of healthcare, such as Himalaya mountaineering and microlight activity, but they're usually in the far corner of the safety margins. As opposed to that, the rest of traditional occupations in healthcare are much, much safer, at least 10 to the minus 3 and beyond, and that, in fact, is our journey in healthcare. In the next slide, you'll see that we talk about when an adverse event happens and you're called to that event, what do you do? So obviously you need to activate a crisis management team, which includes, number 1, containing the event if it's still active, number 2, supporting the staff, number 3, dealing with the patient outcomes, number 4, securing the scene in case there's events that have transpired and you need to understand the device, the implement, or the physical location. Of course, you need to communicate the events to the family, to the patient, to the board, to your C-suite, to bosses, as well as to other people like the media. So clearly, there's a whole range of activities that you're going to need to learn about. Today's podcast is going to discuss the adverse event analysis, is to say, once the event happens, how are you going to investigate this event, either with a root cause analysis or with other types of tools that we'll talk about in this slide. In the next slide, you'll see our formulation of what happens when adverse events happen. This is based on work of many, including our own team, but primarily out of Jim Raisin's work. At the top of the slide, we have the system threats, which include organizational risk factors, environmental risk factors such as noise, tasks such as, for example, putting in a central line or administering a high-risk medication. And then, of course, risk factors related to the patient, for example, aged patients, patients who are obtunded, patients who are hypovolemic. These then are mediated through human errors, either technical or non-technical, that may lead to minor problems or major problems. And if they're not addressed, they lead to an adverse event. The Iceberg Model of accident causation suggests that most near misses and most process failures that don't lead to adverse event outnumber adverse events at least by a ratio of 10 to 1, and perhaps some would say a ratio of 40 to 1. What that means is that there's a rich opportunity to learn from near misses and non-adverse events in which no harm was done, but still a process failed. As you can see from the iceberg, most of the iceberg is under the water. Again, you can characterize that similar relationship between the amount of benign events or near-miss events and an actual adverse event that leads to harm. Donald Norman, one of the forefathers of human factors, published this important book called The Design of Everyday Things. And in this book, he lays out the fact that the designer of the system, that is to say, the physicians and nurses and management that design healthcare systems, they're responsible for all errors that happen. And so errors don't just happen, but a system that underlies those errors lead to that. Norman says if an error is possible, somebody will make it. The designer must assume that all possible errors will occur and design it so to minimize the chance of the error in the first place or its effects once it gets made. The next slide lays out a theory with Brian Kaysen and others have highlighted, and what the theory suggests is that in order to understand an event, you have to understand the interaction in concrete context. That is to say, this isn't just a generic perspective, but understanding why people break rules, why they work around the system, and understanding the relationships between the clinical providers. The interpretation is not just based on hindsight bias, but in fact it's in context. And that means that every clinical encounter has a standpoint which changes and responds to events. That change is really the challenge in trying to interpret what happened. In typical RCAs, we tend to have a very limited hindsight bias, but we argue that in fact making sense for the providers is at the heart of any investigation. That means multiple perspectives and assumptions, multiple experiences and histories, and it means multiple contradictions. That's not a problem. That's actually a gift and a value. So how do we help healthcare providers and systems understand that? The risk model that Renan Alberti and I published several years ago suggests that safety is a combination of safeguards and barriers. That is to say, we need to understand the frequency of the events, times the severity, and then times the detection. Ultimately, prevention lies in depth, and that means that we have to first fail those various defenses, then we have to overcome the mitigating factors, and finally, if we don't recover, that leads to an adverse event. The goal in event investigation and analysis is, of course, to better understand the human fabric that's part of the clinical work. Healthcare traditionally is not a system, in fact, because people can't understand what's happening simultaneously in other elements of the system. We need to expand the learning through making sense. So this is based on Carl Weick's work. Unless the providers understand why the system or how the system works, it's very difficult for them to understand how to prevent adverse event. This means distinguishing causal reasoning about patient care and control from the everyday nature of clinical practice. We need to improve the articulation and coordination of care delivery through a more responsive understanding of why things happen, and ultimately design, invent, and interpret changes from the local context. What does it mean to the ER doc? What does it mean to the ICU nurse? What does it mean to the pediatric clinician? That ultimately is the goal of good event analysis. Sidney Dekker, one of the foremost thinkers in the world on this topic, talks about the fact that rational decision-making requires a massive amount of cognitive resources and plenty of time. In the case of an adverse event, it's simplistic to think that we can simply just try to rationalize it out. In fact, there's reasoning happening in many different levels by their focus of attention, goals, and knowledge, rather than some fundamentally unknowable ideal. What he means is that people do not make decisions according to rational theory alone. What matters to them is that the decision mostly works in this situation. That is to say, the context of this situation might be very different than what we had yesterday or tomorrow with the same type of patient. Dekker argues further that in this perfectly normal reaction to the rules being imposed, people are going to break the rules. That is to say, local decisions that made sense at the time, given the goals, knowledge, and mindset, can together become a set of socially organized circumstances that make the system go forward. What this means, in fact, is that when we try to analyze the event post hoc, it's very difficult to understand why the provider did what they did at the same time. This means that the harmful outcome is not reducible just to the acts or decisions by individuals, but really a routine byproduct of the characteristics of the complex system itself. If you don't go this way, if you don't think about the context, it's very possible that we'll lead up with hindsight bias. And what we mean by that is that after the event, it's very easy to assume that any regulation broken or any decision that doesn't seem right is automatically responsible for the adverse outcome. The classic model for understanding adverse events, of course, is Jim Reason's model. In this slide, you can see that there's a linear line of defenses from organizational deficiencies through local factors, active failures, and finally, defenses that fail. But in the next slide, as you can see, that when these defenses have multiple holes in them, like a Swiss cheese model, some holes can line up to active failures. Other holes, due to the fact that there's latent conditions, things that are not caused by providers, but are inherently there because of decisions by management, or because of old facilities, or because of old equipment, or things of that nature. In the next slide, you can see that, in fact, as these holes line up, the defense is in depth. That is to say, the holes necessarily don't line up easily, and that's what gives protection to the patient. Now, in the next slide, you'll see the incident trajectory that works through these holes that leads to an incident. It seems very linear. The holes can line up pre-hoc as well as post-hoc, but in fact, as we'll discover in just a moment, it's not in any way linear because the context in each patient case differs dramatically. Jim Reason's model suggests Swiss cheese in a very static mode, but I would argue that maybe it's brie cheese and not Swiss cheese. And what I mean by that is that, as you can see in this slide, Swiss cheese is very static. The holes seem very straightforward. But in fact, in brie cheese, multiple factors, each necessary and only just sufficient, can cause an adverse outcome. And there are many, many opportunities for failure to happen because there are so many holes. Just as bizarre as asking what was the cause of not having the accident is, what was the cause of the accident? We don't really find causes, we construct them. And what that means is that choices can seem arbitrary, governed by forces other than the evidence available at the time of care. The question when one analyzes a Swiss cheese model, which I'm sure you've heard about, is should you be looking for the slices of the cheese or should you be looking for the holes? In fact, it's not really meant to be taken literally. It's a model, and like all models, it's not perfect, but it guides us in our thinking. It emphasizes the importance of the latent conditions and how they combine together with active failures by providers to lead to a propagation of an incident to harm. It's not meant to tell you where or how big the holes are. This is not drawn to scale, nor why they're there, nor why they change over time, nor how they line up. In fact, it's a schematic model which helps us understand how defense in depth can fail, but it's very dangerous to use that model to reconstruct the event. In complex systems, incident trajectories are often unique. The same type of patient with the same provider the next day can have a very, very different trajectory. What seems in hindsight to be an obvious error, in foresight actually seemed like a good decision. That is to say, addressing what went wrong in a particular incident will only help prevent that exact sequence from recurring, but not the same type of patient and the same procedure. This is very challenging for providers as well as for safety experts. The likelihood of the planets or the Swiss cheese slices to align in exactly the same way is so remote that it really almost never happens. It's more likely that in the next incident, they'll involve a different trajectory and different holes on the Swiss cheese slices. Addressing the specific sequence, then, that caused the incident will not address the potential path of a future incident trajectory, and therefore, we need to be much more nimble and flexible in the learning that we take from each event. What if, in fact, as you see in the slide, the incident trajectory changed from the slide before, as you can see right now? What if, for example, that the incident trajectory is this way? As you can see, the same holes can create dozens and dozens of trajectories, and that means that when you work backward from the incident, you have to keep your mind open to the fact that there might be multiple ways for the exact same system to fail, different than the one that failed today or with this patient, and yet still challenge you to protect future patients. In the next slide, we talk about root cause analysis, and as you know, this is the standard in healthcare. Our work and other work has suggested, however, that root cause analysis, while is a structured way of looking at events from a systems perspective, unfortunately is problematic because events are rarely just the fault of one person doing the wrong thing. People operate in a system with multiple factors. The system can make it easier for them to do the right thing, or it can make it more difficult for them to do the right thing. Therefore, the context and how the system behaves at any given time can be very different, which therefore makes it difficult to protect from each action. We need to look at the multiple contributing factors at the multiple levels. If you don't uncover all potential causes, the event can actually happen again. And finally, despite what is usually said, root cause analysis can be very, very blameful and therefore lead people to clamp down, not speak up, not come to meetings, and ultimately not trust the process. The challenge with root cause analysis is we tend to focus on what went wrong, but why not find out about what went well? The proper investigation of incidents is a core part of developing a safety culture. All systems, even the best systems, fail from time to time. The test of an effective management system is not its lack of failure, but rather what is done in the aftermath of that failure. Every incident, no matter how small, represents a learning opportunity. If we properly investigate the incident and get to its root causes, the system failures or deficiencies that permitted the incident to occur, we have a chance to put in place the corrective actions necessary to avert a repeat of the incident and improve the resilience of the system against further failures. That commitment to constant and continuous reflection, analysis, and review is the essence of an effective management system and critical to achieving a positive safety culture within the business of healthcare. In the next slide, we focus on what we can do if we find out what went right. What went right can be just as instructive as what went wrong. By identifying effective control features, we can replicate them across the system. Good controls that work at a local level, that are accepted by the clinicians and fit into their systems, can work well. Their effectiveness should be celebrated. That is particularly the case in near misses in healthcare, where despite the controls, things went wrong. Those are opportunities, plentiful, no hindsight bias, no guilt, and no shame. I want to highlight another element that Sidney Dekker speaks about, the power of diversity. And what he means by that is that if the focus of an incident investigation remains solely on what went wrong, it's inevitable that it's going to lead to blame. Even in organizations where a just culture is in place, the singular focus on the negative behavior or behaviors can be detrimental to the overall morale and functioning of the system. It also is a missed opportunity. Here's what Dekker says. Complex systems can remain resilient if they retain diversity. The emergence of innovative strategies can be enhanced by ensuring that diversity. Diversity also begets further diversity. With more inputs into problem assessment, more responses get generated, and new approaches can even grow as the combination of clinicians and systems and analysts work together to mitigate those outcomes. In this next slide, we're focusing on the framework of contributory factors from the London Protocol. Here we have a layout of the latent factors, including the administration, the environment, etc., etc. And as you can see, all these elements contribute by creating the conditions, the enabling conditions that allow an adverse event to occur, or conversely, blocking it from propagating to an adverse event. In the next slide, you'll see a list of the active factors. Again, the competencies, the task, the patient components, all these things contribute ultimately to why an adverse event continues on from a bad decision or a failure of a process, ultimately to leading to harm. In the next slide, you'll see another example of a flow diagram, which I suggest you consider using. In this flow diagram, what you'll see here is that we're looking at the various primary causes, intermediate causes, and root causes. And as you can see, there are multiple factors that really allow you to go from hypotheses about what happened, what you see and where, and finally, what was the human experience beyond any individual experience. You can see here that the process is evolving, it's dynamic, and ultimately that these wicked problems are deep within the organization and therefore cannot simply be resolved by addressing one factor, but really the relationship between these factors. The key issue around the root cause analysis format in the London Protocol is to be aware of oversimplification. What I mean by that is be wary of cherry picking, be wary of static snapshots. You need to learn to look for interactions, not independent factors. Nothing really, as you get to do this more and more, is truly independent. There's great room for improvement in the slow-to-respond system, and that's not the same as a tight chain of causality. And what that means is that you need to be aware of the fact that what seems in hindsight to be a simple cause and effect might actually be caused by multiple intermediary factors that you can't necessarily see, but in real time contribute to the mindset, the decision-making, and the ambiance in the organization when the event happened. In this cartoon, you can see this lovely example about flowcharting, and it reads, "If you won't believe me, maybe you'll believe the brainy-looking exec with the flowchart." Again, what's clear is that just because you have nice flowcharts and PowerPoints, that does not necessarily mean that you can actually prevent a future event because of this interactive complexity in the elements that happen. In the next slide, you'll see that cause and effect diagrams are very powerful. They move the team from the proximal context of the incident to consider concepts that describe the latent factors. They give a sense of what people were doing at the time in contrast to what else was available. The downside, however, is that they sort data according to abstract categories that don't make sense to providers. They may dismiss valuable input if they don't nicely line up with the root causes. And finally, root causes are not an ultimate endpoint. They're simply the limit of the team's investigation. That means that the root causes are not an ultimate endpoint. They're simply a byproduct, and they can only be simply the limit of the team's investigation. All of them together might not necessarily help you understand the complete essence of the event, and therefore will not help you prevent future events. In the next slide, there's another cartoon for you to consider around the complex series of breakdowns, and this reads, the key difference with the new plan is that what we once feared now is our best case scenario. Obviously, neat categories of causes look lovely, but don't necessarily explain the complexity in the real clinical scenario. Question is, in our next slide, are our goals and root cause analysis realistic? Here's a quote from a company that offers services. Every error has at least one root cause, and every cause has a solution. Using a structured, evidence-based approach like Six Sigma will help you identify and address the underlying causes of errors and inefficiencies in healthcare. Clearly, this is not just oversimplistic, but is doing a disservice to healthcare by suggesting that there are such thing as simple root causes. In fact, there rarely is such a thing. What I would encourage you to think about is the richness of the interplay of causes, and therefore the context dependency of each of these elements. Here's a clinician's perspective from Atul Gawande's book, Complications. Here's what Atul writes. Many doctors take exception to talk of systems problem and process re-engineering. It is the dry language of structures, not people. Something in me demands an acknowledgement of my autonomy, yet although the odds were against me, it wasn't as if I had no chance of succeeding. Good doctoring is all about making the most of the hand you're dealt. It isn't reasonable to ask that we achieve perfection. What is reasonable is to ask that we never cease to aim for it. This is an important quote, and it suggests, of course, that we as analysts after events need to be much humbler about what we think was going on in the heads of providers as they were approaching the patient. This work that we did several years ago, published in the British Medical Journal, suggests that these interplaying factors, the patient factors, individual factors, technical factors, organizational factors, staff factors, and team factors all play together to create and prevent a mishap. And therefore, understanding how they play together is hugely important in your arsenal if you're going to prevent future events in your organization. Another way to approach adverse event analysis is through work domain analysis. And what work domain analysis shows, based on Kaysen's and others' work, is that by understanding the connecting patterns between the patient, the clinician, the local clinical team, the workplace interaction, and the organizational goals, we have a much higher chance of understanding how to prevent future events from happening. This is a very different approach from root causes, which tries to identify one cause. In fact, in work domain analysis, we try to identify multiple interrelating causes because it more closely mimics how providers behave, and it makes sense to them in how they construct their world and how they actually focus on patient care. In the next several slides, you'll see a diagrammatic analysis of how an organizational accident causation, working from the organizational approach to the workplace, to the person team, ultimately to the error-producing conditions such as fatigue, time shortage, poor human system interfaces such as EMR and HIT, information overload, and distractions, all, of course, create conditions for adverse events by providers. Not least, of course, is the inexperienced providers, either junior providers working above their station or even experienced providers without supervision and with inadequate checking, such as refusing to do surgical checklists or refusing to double check something such as a blood transfusion. When you take all these things together and you add to that the violation-producing conditions, the lack of a safety culture, management staff conflict, poor morale, the normalized deviance, poor supervision, and ultimately an environment that condones violations and misperceptions of hazards, all this together leads to a problem of adverse opportunities. We shouldn't also forget the lack of management concern and the fact that more and more data shows that providers are burnt out and unhappy and they have very little pride in their work, which connects to the fact that they believe that bad outcomes won't happen to them and leads to the fact that they don't believe that they should actually change their behavior because nobody's going to catch them or the rules are ambiguous, meaningless, and don't apply to them. Again, if you look at the relationship between the organizational accident model from the left, from the organizational factors through the workplace factors, through the person and team factors, ultimately trying to permeate and penetrate the defenses, you move from individual errors ultimately to adverse events. It's important to focus on also the individual provider and why they do unsafe acts. We should separate between errors and violations. What I mean by that is most people, when they create errors, they don't do it deliberately. Those are attentional slips and memory lapses. They can be omissions or intrusions. They're mistakes that can be based on rule-based or knowledge-based. All this is very different than violations. We define violations as a deliberate deviation from regulations or norms. That is to say, you're told not to do something, you were taught to do something else, the instructions on the drug or the device says, and despite that, you violate the rules. You do shortcuts, you optimize violations, you exceptionally break rules, and you deliberately either break a process. Those are very different than errors, and in fact, they're a minority, and we need to treat them quite differently than the majority of adverse events which are caused by simple human errors. Again, to go back to the model in the next slide, the alignment of the organizational factors, the workplace factors, the person-team factors, ultimately penetrating the defenses leading to accidents. I want to wrap this up with a few final slides. First of all, with a quote from Captain Daniel Marino, who's a human factors expert at the International Civil Aviation Organization. Daniel says as follows: "No matter how well equipment is designed, no matter how sensible regulations are, no matter how much humans can excel in their performance, they can never be better than the system that bounds them." What this lovely quote highlights for me, and hopefully in your work towards becoming a better safety analyst, is that you might think, based on post hoc analysis, that you understand the interaction between the regulations, the culture, the behavior of the providers, and the outcomes. But in fact, the system is so much more powerful than any of those elements together, and therefore understanding how they interact, how they enable, how they lead providers towards failure is hugely important as you're trying to reconstruct what led to this adverse event. I'm going to summarize with 2 slides. This slide entitled Conclusions. The challenge, of course, is that we don't fall victim to the temptation to oversimplify causes of incidents, to simply relying on root cause post hoc analysis. But the imperative in the aftermath of an incident is to minimize the impact of the incident. That means reducing shutdown time around patient care. That means addressing issues such as equipment and regulatory actions. This often leads to reactive and narrow-focused decision-making on corrective actions. For example, quickly trying to design new working procedures or training courses. This is the most popular corrective action. It has the least lasting effect and rarely actually leads to improvement. The assumption is that if we identify the cause of the incident, we can simply develop a procedure for addressing it, train workers, develop more equipment, etc. The reality, as we've discussed in the last 30 minutes, is that in fact the complexity in interactions means that simply because we think we can hindsight look back into the event, we neglect the fact that we might misunderstand the context and the multiple trajectories that can happen with the exact same antecedent factors. This root cause analysis type approach can satisfy the regulator, management, and crucially is cheap, but it doesn't necessarily make the organization safer. It doesn't make patients safer, because at the end of the day, the key barrier to change in healthcare is that, like Peter Drucker says, culture eats strategy for breakfast. And what I mean by that, what Peter means by that, I should say, is that whatever we think we can strategize for safety, we need to remember that the underlying culture in the organization, at the microsystem amongst the team members, for example, in an ICU, at the mesosystem amongst the chairman of departments or chiefs of services, or at the macrosystem at the level of the CEO, at the level of the board. That culture and how we do things here, how we treat people, how we respect people, how authentic we are when things go wrong, that ultimately is going to trump and overcome any type of policy, practice, or strategy. As an expert in analyzing adverse events, your challenge is going to be how to uncover that culture, how to understand how that culture led to the conditions that ultimately contribute to the adverse event, and how you're going to address the changes that are required in the culture while using the learning from this event to help understand, as well as to help others understand, how the culture contribute to the event and therefore the challenges and the type of interventions you're going to instigate in order to prevent this culture from leading to future adverse events. Thank you.